Good morning, everybody. I want to thank you for taking the time out of your schedule to join us. This is the second webinar in our Rural Nursing Innovation Series, so we are grateful to have you with us today. Before we get started, I just want to share a brief housekeeping message that we are going to be holding all of our questions and answers until the end of the webinar this morning or this afternoon, wherever you may be calling in from. But please feel free at any point in time to use the chat feature or the Q&A feature in your Zoom panel if you want to share your message so you don't forget it. But just keep in mind that we will be holding those until the end. It's my pleasure this morning to introduce you to our presenter today. Fiona Hildebrand is a registered nurse who is driven to improve the quality of healthcare for people residing in remote Australia. She has practiced primary healthcare in some of the most far-flung remote places, such as Aboriginal communities, mine sites, immigration detention centers, and once she worked on an island resort in Whitsunday, which is actually not as glamorous as it sounds. She worked for scabies prevention and ear disease projects that were rolled out across the top end of the NT. After clinic practice, Fiona worked as a clinical manager in the Northern Territory for the Remote Area Health Corps, a government-funded organization to upskill health professionals from urban areas to work in remote Indigenous communities. She then worked for the Marjolin Kimberley Center for Remote Health in Broome, Western Australia, as a rural and remote nursing and midwifery lead. You'll now find her residing in the southwest region of the Western Australia, working to set up the new University Department of Rural Health at Edith Cowan University. Fiona holds a Bachelor of Nursing, a graduate certificate in remote health practice, a graduate certificate in social marketing for health, a master's in public health, and is currently a PhD candidate. And now I'd like to turn it over to Fiona. Welcome.
Thanks, Stacey. That's a very lovely, warm welcome. And thank you, everyone, for joining me today on this presentation, and for people particularly who are joining live, but also for those who are watching this after this session. I'll just share my screen. In my husband's office, so everything's a little bit messed around from what it normally is. So excuse me if I pause for a moment here or there to just figure what's happening. Okay, so as I said, my name is Fiona Hildebrand. I currently work for the University Department of Rural Health Southwest, and there's 19 university departments of rural health around Australia. It's a government initiative, so we're federally funded. And what the intention of these departments are to support the regions that we are in, and that's to grow the health workforce, non-medicine health workforce. So we have support registered nursing undergrads, midwifery, and allied health. And one of the main aims is for people from an urban centre to come to the region, have a placement, and experience the wonderful life that is living in the country. And then they often have that taste and they leave wanting to come back, and that's how we reel them in to work in the country. What I'm presenting today is a clinical supervision model for remote area nurses, a scoping review. I'd just like to acknowledge the country which I'm meeting you from today, and that's the Wadandi people of the Noongar Nation. I want to pay my respects to elders past, present and future. And I want to acknowledge that this land always was and always will be Aboriginal land, and I want to acknowledge the land on which you're meeting us from as well too, and the First Nations people that are from that land and might be joining us today. So this is me. I'm a registered nurse, trying to get her bearings on where the mouse is going, sorry. I grew up in rural and remote environments, both in Papua New Guinea and in Western Australia. I was about 1,000 miles to the nearest city. And so I had rural and remote in my blood, I guess, from the moment I was born. I've worked all across Australia, and as mentioned prior, I've worked in industrial settings, Indigenous, humanitarian communities, across a broad spectrum of areas. I've always been interested in social disparity and the social determinants of health of people that lived in remote communities, but I've often felt helpless to support them in this disparity. And so this is me and my husband and my daughter. My husband's Indonesian. That's our dog is a blur in the background, and that's us on one of the furthest beaches in Western Australia. We love just getting out there. And so you might be wondering why I'm telling you all this personal stuff. It's because I'm doing qualitative research. I'm really embedded in what I'm doing. And so remote communities in Australia have the poorest health of everyone. They have low access to comprehensive care. They are isolated populations that are physically distant to access either by road, boat, or aeroplane. They have significant cultural differences from the urban population, and they are often run as primary healthcare centres that are either government or Aboriginal and Torres Strait Islander organisations. Remote area nurses work in isolated conditions, often without general practitioners on site, so no doctors working with them. There's a very high turnover of staff, people coming in one day, the next they'll be out in a few weeks. There's low recruitment and retention. They're physically distant from a tertiary care centre, so they often have quite acute things they need to deal with without support. They also provide a wide breadth of care from cradle to grave, they are a true generalist. They require advanced practice and generalist knowledge and skills, and they work out of their scope, which I wrote that in a paper once, and I was told I shouldn't say that, but the evidence is out there. They work outside of their scope. That's what people are saying they do. And here's me working well outside of my scope after a dog was speared in a remote community. There was nowhere else for the owners to go to, so you just do what you can. I was on the phone to a vet, getting advice and helping out, and I advised them to travel to the vet, which was 3 hours by a corrugated road. After I'd finished the treatment, because I wasn't sure how the dog was going to go. But I saw the dog running around in a few days, and it had survived my poor veterinary skills, and they elected not to go to see the vet. So that was pretty lucky for me. So I've noticed a lack of pathway and oversight for remote area nurses, and that's despite remote area nurses caring for really vulnerable people. And people I've talked to, other remote area nurses, have also said they've felt the same way. And so I've been looking at whether clinical supervision is a potential solution. This triggered my PhD journey, and so this is a long definition about what clinical supervision is, so please bear with me. It's a distinct professional activity in which education and training aimed at developing science-informed practice are facilitated through a collaborative interpersonal process. It involves observation, evaluation, feedback, facilitation of supervising self-assessment and acquisition of knowledge and skills by instruction, modelling, and mutual problem solving. Building on the recognition of the strengths and talents of the supervisee, supervision encourages self-efficacy. Supervision ensures that care is conducted in a competent manner in which ethical standards, legal prescriptions, and professional practices are used to promote and protect the welfare of the client, the profession, and society at large. So I chose this definition because it really rung true about what we need for remote area nurses. We need people that are competent, but we also need people that can work autonomously. There are some professions that are familiar with clinical supervision, and These are mental health professionals. This is mainly in Australia too. Having a bit of a tech problem. These are mental health professionals, psychologists, counsellors, mental health nurses, general practitioners, also social workers and other allied health professionals. And supporting the health professional to reflect on their own practice is a major component. So why could it work? So nurses who receive clinical supervision feel well supported, and they also provide a higher quality of care to patients than those that didn't receive clinical supervision. And so this is even more so, more marked for nurses who are developing their skills and knowledge in advanced practice. Clinical supervision results in greater clinical reasoning and safer clinical practice. And for nurses that work in stressful environments, it's recommended that formal clinical supervision is employed to develop social support, self-care, mechanisms of coping to combat vicarious trauma. So my PhD journey has begun with the overall question of what will help remote area nurses work within their extended scope. So I've signed up to submit 5 papers. So I'm doing a thesis by publication. And the content of this presentation is based on the first paper, which is a scoping review. So the research question for this particular scoping review was, what clinical supervision models are reported in the literature that could be used for nurses working in remote health practice? So the literature review, I looked at the PICO framework, I looked at a generalist population, the intervention was clinical supervision, the context primary healthcare, and I was looking for a description of a clinical supervision model in the literature. The search strategy included primary care or primary healthcare and clinical supervision or professional supervision. I excluded undergrads, non-generalists such as pharmacists, surgeons, and mental health nurses, and those roles that require direct, constant supervision, such as physician's assistants, and any that were published outside of the last 25 years. Those were included, were in English, referred to a specific clinical supervision model, and were primary healthcare specific. And so this is just the process that I went through, and in the end, there were 11 studies that were included in this review. So what did I find? Those who undertook the clinical supervision models in this review were general practitioners, practice nurses, and nurse practitioners. And the models were from United States, Denmark, UK, and Australia. So these are just some examples of the models that were in the review. This is the beta-lactam, and this is a clinical supervision model for supporting trainee GPs during consultations. And so it gives a framework of how to work through that clinical supervision of a supervisee. This is the triggers for seeking help. And so this is a model that mutually negotiates for the trainee GPs to reach out for assistance for specific conditions or circumstances, and in the fashion that they choose to have that support. So that might be a video consultation, in person, via message, for example. And this is the Kalimnos model, which is from a group reflective sessions, and they use the windows. And so, for example, the supervisee specifies what went well and which feelings the patient evoked. And then the group say, if I was in this supervisee's shoes, what feelings would I have? And then it goes back to the supervisee about what they think went well. And so this has a fairly non-blame kind of approach, or makes people feel a bit safer in saying how they felt and how the consult went. Also saw random case analysis, and so this is where the records of doctors were checked, GPs were checked, and fed back information about patient notes or consultations, and this was done at random. There wasn't a lot of detail about this, but it was really, it seemed to be quite a good way of providing supervision that wasn't intrusive. So from there, a hybrid model was developed pertaining to remote area nurses. So I know there's a lot in this, and I'm sorry for that. What I'm going to do is talk about these sections individually, so you don't have to read it all right now. I'm going to go through it. So the first section is the in-person supervision support. So that's when the supervisor is in person, side by side with a supervisee available within the clinic for 1 to 2 weeks. And then they use the triggers from the primary care manual. So in Australia, we have primary healthcare manuals for people working in very remote areas where they don't have a doctor on site. And I'm not sure what happens in other countries, but this in effect are doctor's orders that are written down. And so you go through your consult, you say, as per page 59 in the manual, I did all these tests, the patient has this, and the manual says that I need to give this. And so from that manual, we can make triggers. So if a person comes in with a fungal toe, for example, and the person's not feeling very confident about dealing with this, then they could say, okay, I'm going to contact the supervisor by message to get immediate help about how I should proceed with this. And so the triggers are negotiated and they'll change throughout the person's level of competency. Debriefing occurs daily, and the beta-lactam framework that I showed earlier guides the supervisor support for the supervisee. The next part of the model is where online small group sessions are conducted and individuals present a case that has been video recorded. The group and the supervisee work through the case using the prompting questions as per the Kalymnos model that was shown earlier with the windows. Using the random case analysis model in this section, case notes are checked via electronic health records, and across Australia, pretty much everyone has electronic health records now. And so you can beam in from another state or another country if you wanted to, and you can provide feedback on the style of notes and the ability to, or the capacity to have missed something. So then the supervisor provides feedback to the individual. And then the last part of the circle is the on-demand distance support. And so there might be occasions in which the supervisor would like to discuss their case immediately or choose a time. The triggers that we talked about earlier will support this, meaning that they'll figure out immediacy, the style, message, email, phone call, or video call. So that will all be negotiated. And the final part is in my reading, I found that any nurses who had clinical supervision that weren't aware of what was involved didn't seem to be able to use it as effectively as it could be. And so that's the intention of having a short course at the start for the supervisor and the supervisee, so everyone can get the best out of this relationship. So the model's been developed. What now? Where do we go to now? So I've conducted interviews. I've done focus groups. And the model's been developed a lot further, so it is almost purpose fit to be able to be used, but I'll be needing further input. So I'm reaching out to anyone who's a remote health manager or a decision maker, and I'm particularly interested in whether in other parts of the world the model looks like it would work, or if it's very Australian-ific. So please reach out if you'd like to have a chat or be interviewed for my study. I'd love to talk further. And so I just wanted to almost finished with this quote. Whilst remote area nurses work in isolated areas and often away from direct clinical supervision, their practice should always be open to scrutiny. Providing healthcare to vulnerable groups of people is serious business and requires skilled, prepared nurses who are prepared to be ongoing learners and reflective practitioners. And I'd like to share some imagery that helps me imagine what a clinical supervision model for remote area nurses might look like. So if we imagine this tree is a remote area nurse, their roots indicate their grounding in their undergraduate education. The trunk is the solid experience as a nurse, and the flourishing leaves at the top are the wide range of up-to-date knowledge and competence that a remote area nurse requires to perform their role. And this might be an example of a nurse that comes to work in a remote setting, and perhaps they're from an urban area. They bring amazing skills and knowledge from their background. However, they need a broad generalist set of skills and knowledge to work in a remote setting. And clinical supervision has the capacity to be these connecting branches, to have flourishing competence across the broad spectrum, which is required in remote health. So just show that one again, because I'm looking for participants, but I'm happy to have any questions now if there's any.
Thank you so much for sharing that wonderful presentation. If you have any questions for Fiona or any comments that you would like to share, please feel free to use your chat or Q&A feature, and we will pass them through. Following the webinar, if you do want to get in touch with Fiona, I know she had her information up on the website previously. They're asking if you could please post your QR code again. Do you want to pull that up? Is that something that you could pop in the chat too? Either way.
I don't have it. Is it there?
Nope, that was your end screen.
Just one moment. Okay.
As that's being pulled up, I'm just going to drop into the chat as well the contact for GRNEN. If for any reason you don't have that information, or if it gets lost along the way and you need to get in touch with Fiona, you can always reach out to us and we'll make sure you get connected. But there you go. It should be up now if you want to take a screenshot or capture of that. Thank you. Okay, any other questions? We have a question coming through. Melody says, thank you. Here in the US, I teach NPs and we're trying to focus on rural. I really like your model. Licensure for NPs here in the state of Idaho does not require MDDO supervision. Do you have any thoughts on that?
Well, I'm actually thinking with the remote area nurses that supervision would be from remote area nurses rather than from any other health practitioners, because they get it, they understand, they do the on-call and the call-outs at 3 a.m. and yeah, so I think it would be preferable to have remote area nurses doing the supervision. It's not compulsory here at all, so that's why I'm really looking into it, because there has to be a better way of supporting remote area nurses. People have to travel to do courses, then that means they're out of the community. I was trying to make this model as in place as possible to be able to help people while they're in the, they're in the mix of having to provide the care. Yeah, so I'm hopeful that we can adopt this in other places, but it would be great to trial it here first.
Thank you.
I'll stop share now so I can see a bit better.
Any other questions today? Following today's webinar, we will be placing this on our website on the on-demand webinar page. So if you need to reference back to this for any reason. If you have colleagues or peers that you would like to share this presentation with, we of course encourage you to do so. Next week on the 24th, we will be continuing the Rural Nursing Innovation Series with 2 webinars. You can also find that directly on our website. And again, if at any time you have a question that pops up after the fact, you can always reach out to either Fiona or to myself, and we will make sure that you get that addressed. Keisha is hoping to ask a live question, so we can go ahead and open his mic on that. Keisha, you should be able to use your mic now.
Thank you so much. Congratulations, Fiona. I'm sorry to pronounce maybe wrongly.
Oh no,
I
that's
was
perfect.
following your presentation carefully, and your concept of supervision, of course, is critical. It's critical, but my worry is, so I know the situation in the rural area. The rural area people, they are practicing even beyond their scope. So I was asking myself, what will be the impact of this model? What will be the impact? You wanted them not to go beyond their scope, or I don't know. Maybe you can help me to clarify on that. On that. Thank you.
Okay, sure. So necessity means that the individuals that RANs, remote area nurses in Australia, they need to work outside of their scope. However, their scope is determined by what they're comfortable and competent in what they're doing. And that's how we identify in Australia. So what they have, the education, they have the confidence and, you know, the competence as well to be able to do that. And so to be able to help them work within their scope, then that knowledge, competence and comfort or confidence, that they all need to increase to help them work within their scope. Does that answer your question?
Because even in the other countries, we have a professional regulatory body. And that is what we normally define the scope of practice for the profession. And if you bring with that, of course, due to the scarcity of the healthcare workers in the rural area, and that is why the nurses also, they do other activities which are beyond their scope, but it's rural experiences, normally they do that. So now you are coming with the concept of supervision. You wanted to develop a framework to address that kind of gap. So what will be the impact? My question is, what will be the impact of your innovation, of your model in the rural environment?
Yeah, well, my hope is that it's broadly adopted in Australia, and that raises the quality of care for people residing in remote communities. And I'm not sure if you know, I probably didn't include it in the slides, but in Australia we have quite a large gap of life expectancy between Indigenous and non-Indigenous people, about 20 years. So it's terrible. And those people are the most vulnerable, so they deserve the highest quality of care. And so my hope is that they'll be able to provide better care. More broadly speaking, currently Australia is going through some big changes with a scope of practice review from the federal government, and there's a lot of quite nervous GPs right now because they're looking at widening the scope of practice for nursing, midwifery and allied health. And so it feels really timely right now to be getting this research out there. And I think actually remote area nurses are at the forefront of working to the top or beyond their scope. And so it's useful to demonstrate that it can be done, but we need the safety mechanisms around that to be able to do that in a safe way. And I'm hoping that clinical supervision will become that accepted form of support.
Thank you. I have a question from Melody Weaver. Melody, you should be able to ask your question. Are you there? Okay, maybe that's not working. I think I have one more in the chat. Okay.
Oh, sorry, Kija. I hope I'm saying your name right. We do have a regulatory body, absolutely. However, it's almost like in Australia, because it's so vast and it's there's no oversight of people in remote areas, and so the regulatory body often doesn't know what remote area nurses do. And it's a very small population of people as well too.
Thank you. Melody, I see that your mic's not working. If you want to share your question in either the Q&A or the chat, please feel free to do so. We're coming upon the time limit that we have scheduled for today. So if you want to pop that over, please feel free. Alternatively, you can also reach out to us after the fact. And like I said, we'll make sure that if you don't have the ability to reach Fiona directly, we'll connect you for sure. So once again, thank you for everyone for taking the time today. Fiona, thank you so much for sharing this important discussion. We're so grateful that you took the time to be with us. I know that it's quite late, so we wish you a good night.
Thanks.
We hope to see everybody at a future webinar soon. So thank you everyone for your time, and take care. Have a wonderful day.
Thank you. Bye.